Hi everyone, welcome to Community Health Media. I'm excited to be here in beautiful Seattle, and before I introduce our guest today, I think some of you know I'm originally from Seattle, so I got my Seattle pride out with my Seattle Mariners hat, if everybody can see that. I'll put that to the side. So I'm joined today, well, before I tell you who I'm joined by, V.K. Gadi. I originally was here from Seattle, was at the Fred Hutch for about 20 years, and I moved to Chicago, where I'm now the Deputy Director of the Cancer Center in the University of Illinois Cancer Center and the University of Illinois Chicago, in Chicago, Illinois, of course. I'm a breast medical oncologist and delighted to be here and hosting another one of these chats. Today I'm joined by Fengting Yan. Fengting, if you want to introduce yourself a little bit.
Yeah, good evening, everyone. I'm Fengting. I'm a breast oncologist at Swedish Cancer Institute. I had my oncology fellowship training at the Fred Hutch, and V.K. was my mentor at that time. It's my privilege to be here with V.K. today.
All right, Fengting. So maybe you could describe your clinical practice a little bit, just so everybody knows your expertise.
Yeah, absolutely. I'm a clinician. I see patients 4 days a week, and before I came here today, I only saw 23 patients today. Traffic was not as great as I was hoping for, but I was on time. And 95% of my patients are breast, and I do see 5% of other women's cancer, gynecological cancers. Of course, every day, breast cancer is what we are dealing with every day. Early stage, high risk, stage 4, and those are the patients we treat on a daily basis.
So Fengting, you're an academic physician. Your practice has clinical trials. You're very active in this space. Maybe you can tell us a little bit about your clinical trials expertise and what you focus on in your day-to-day practice in terms of research.
Yeah, absolutely. I strongly believe research, that's how we have all the care options today. I'm a big believer of research and clinical trials. So at Swedish, we do run phase 1, phase 2, and phase 3 clinical trials, and besides all the phase 3 trials, and I do lead quite some phase 1 and phase 2 trials. It is to look for new medications and new treatment options, and often the time that give my patients hope that we can offer options even there is no standard care available. At the same time, we want to optimize the care we have every day. And perfect example in breast cancer treatment would be if a medication is doing great in later line in stage 4, why don't we move it up to second line, first line? If it does well in the metastatic setting, why don't we move up to early stage and to prevent patients from getting stage 4 cancer? So that has been my interest, not only to look for small molecules and newer targets, but also how can we personalize and optimize the care available with the available treatment options.
Perfect. So I know you're one of these doctors who has their ear to the ground on everything going on, and that's why I really wanted to kind of get that out of you. With that sort of background, maybe you can share with us a little bit about your thinking around how we identify when a cancer is HER2 driven versus HER2 something else. Walk me through your way of how you figure this out for patients that are coming to your door.
Yeah, of course, HER2 is the most important marker in breast cancer, and it's not only a biomarker, it's oncogenic. That's how we can never emphasize enough that we can never ignore the HER2 treatment. And in my opinion, that's the most important discovery in breast cancer treatment besides the estrogen receptor. And it's great for us to make such progress that we realize it's not only HER2 positive patients would benefit from HER2 targeted therapy, and now we are moving on to HER2 low and HER2 ultra low, and that makes a lot of sense in the scientific rationale in the way that as long as there is HER2 expression, and perhaps we may target that important biomarker and oncogenic marker. So for all my patients came to me, of course, when if they are HER2 positive, we absolutely want to prioritize the HER2 targeted therapy. But nowadays, even it's HER2 low and HER2 ultra low, we teach them up front that, yeah, we have not needed the HER2 targeted therapy yet, but it will be on the table later.
Got it. So just to clarify, let's walk me through an example. Okay, brand new patient has a liver met or something, and you put a needle in it. You get the tissue. Walk me through the strategy that you and your pathologist do in terms of following the guidelines with how you determine first if it's HER2 driven, and then what you do in terms of finding if it's HER2 low?
Yeah, absolutely. Of course, the first question is always the first, and every time when I get a consultation, my first reaction would be, where is your ER and HER2 status? Of course, after the, let's say, a liver biopsy, and the first step is always we want to perform the immunohistochemistry. And that's 3+, great. It's a HER2 positive, and we will want to pursue the HER2 targeted therapy. And we have newer updates on that, and I'm really excited about that. But when it's 2+, of course, we want to go ahead with ISH or FISH to make sure we don't miss any HER2 positivity. But when the 1+ or 2+ but negative by FISH or ISH, we tell the patient up front, this is a HER2 low breast cancer. HER2 targeted therapy is not upfront therapy, but it will be available for you later. And for the HER2 0, and we are changing the practice nowadays too. In the past, we tell them, oh, well, this is HER2 low, or HER2 negative, and HER2 targeted therapy is no longer available. But now with the Ultralow concept, I got to talk to the pathologist. We actually have the report. When it's HER2 0 biopsy, we actually have the report, it's Ultralow. In that way, up front, we tell them, yeah, even it's 0 biopsy, but we do see some signal, and this is HER2 Ultralow, and the HER2 targeted therapy will be available later. We give them the expectation up front. In that way, they are expecting the HER2 targeted therapy later, even if it's HER2 low or HER2 Ultralow.
And just to clarify this, you would do this even in patients that are ER negative, correct?
Yeah, correct.
Okay. So
correct.
Regardless of ER status, you're looking at HER2 immunohistochemistry for everything from ultra-low all the way up to 2+, and then for the 3+ as well.
Yeah, absolutely. Even for the ER negative patients that HER2 low and HER2 ultra-low, potentially they can be eligible to receive HER2 targeted therapy.
Okay. And then, there's been a lot of work. We've talked about this in the past, but the cancers that are HER2 driven, that's easy. But it's also true that when it's not HER2 driven, in other words, the 2+ and 1+, that biologically doesn't mean anything, right? It's just a convenient target that you can then attack with a drug like an ADC, like trastuzumab deruxtecan.
Yep.
Have you seen anything contrary to that? I haven't. I'm asking you. I just haven't seen anything where HER2 low means anything biologically.
Biologically, I do not think when it's HER2 low or HER2 ultra-low, correct me if I'm wrong, I no longer think they are the primary driver, and I do not think they are oncogenic. Yeah, it's convenient to target for that. But in the low or ultra-low setting, I truly think it's more a biomarker.
That's what I've seen, so no differences there.
But it is true, though, the observation has been, interestingly, clinically, the HER2 low patients tend to do slightly better than the HER2 negative. That's just an interesting observation.
Yeah. Okay. Well, with that was an excellent start. That's actually what I wanted to clarify, because I think precision medicines are great, but if you don't know who you're going to give them to, it doesn't work, right? So we need to get that first and make sure we understand that. Before we jump into the new data, particularly from San Antonio, but then some of the updates that just happened a few weeks ago, not even a few weeks, last week at ASCO, I do want to just rip the Band-Aid off and say something we're not going to talk about, which is DESTINY-Breast09, big release at ASCO this year. Early morning presentation, very thought-provoking, but maybe your initial impressions. Obviously, this is this trial where it's not fully reported. This is an interim analysis on just one of the investigational arms of TDXd plus pertuzumab versus the THP classic regimen for first-line therapy. Positive study. I don't know if you have initial impressions. We just want to get this out of the way so we can focus on the other stuff.
It's very interesting. I'm not going to disclose the oncologist's name. She might be in the audience. On my way here, I received a text message. Fengting, I'm seeing this 29-year-old woman. She is stage 4. Have you ever used TDXd and pertuzumab as first line? And my answer was like, well, I'm very excited with the data, but it's not the standard of care yet. We still have to wait for more data. It's very interesting. I already got that question on the way here.
Wow, that's amazing.
I know, and I think the rationale for the oncologist to ask me that question, this is a young woman, aggressive disease, and it's absolutely appropriate to look for more effective treatment up front, and I think the question was legit, and she's on top of everything, and I totally got that. And absolutely, I was never surprised with the results. I was expecting a positive results. I will be shocked if it was a negative study. I was expecting that. I'm excited to see that for effective treatment options, and it makes a lot of sense to look into give them earlier rather than save them for later. I won't be even surprised if we start to move the treatment in the metastasis setting to early stage. I won't be surprised in future.
Yeah, okay, that's great. I'm glad you got it out. 40 months of the PFS top line data, but a lot of the details are still not out. There's no publication. It's a, so we'll see.
Hopefully soon.
We'll see what we learn, right?
Yep.
Okay, we got that out of the way. I'm glad we could do that. So let's really actually pivot then to kind of the main topic of tonight, which is really this mostly ER positive type patients that have low or ultra low quantities of HER2 expression. We've originally had the DB04 trial, which going back now a couple years already, it's hard to believe, where we looked at patients who had mostly had a prior line of chemotherapy and then were permitted to be on this study with ER positive and ER negative disease. I'm just summarizing here. It was a positive trial, meaningfully different for PFS with an OS benefit that was also emergent, and changed really the practice in terms of giving another non-chemotherapy option for patients with HER2 low disease, regardless of hormone receptor status, and clearly made the NCCN guidelines. I think the next study, of course, is DB06. Maybe you can summarize that for us a little bit and tell us your impressions of the original data, and then we'll dig down a little bit more on some of the more recent data that's been published.
Yeah, and we actually participate DB06, and first, and actually it was, I think, 3 years ago. Literally, I had a flight at 11 p.m. that day, and I saw a patient right before my flight, and I consented her to DB06. I'm very proud of myself. So, of course, DB06 is when those patients in the hormone receptor positive, HER2 negative setting, after they progress on endocrine therapy, and we randomize patients to TDXd versus physician choice of chemotherapy. Of course, for the patient I consented at that time, I put her, she was randomized to physician choice of option. Of course, I put her on capecitabine. It's oral and it's easy. It was a positive study, and with the PFS benefit, and of course, the question would be, how do we position the TDXd in the setting? Yeah.
Do you, in your current practice, for those patients that are HER2 low or ultra low, because this is the first study where we had ultra low, so this is 85% of hormone receptor positive patients now. Do you currently favor TDXd, or do you have some decisions or patient discussions on kind of not doing TDXd right out of the gate?
For me, it's not 100% yet. My strong believer of personalized treatment, and I do have a good discussion with my patients. Actually present the data to them, even they are HER2 low or HER2 ultra low, I present the data to them. But there are some patients, they still favor oral agents, and they still prefer not even risk 1% of the chance to lose hair, and those patients do exist. Truly, again, I truly want to emphasize to everyone that we want to prioritize and use the most effective treatment upfront in the earlier setting rather than save for later, because each time when we switch treatment, we're losing patients. So for that reason, I truly favor to use that, but it doesn't mean 100% of my patients would favor IV therapy. And in the ER positive HER2 negative setting, it's almost like a switch in the way they have been so stable on oral therapy. Sometimes the patients, or even myself, would have hard time to say, let's start the IV treatment, you no longer have any oral therapy. So I absolutely would adopt the data, and actually talked about the data with all the patients, but there are some percentage that we still use oral agents.
So in the original DB06 presentations and also the papers, obviously every subgroup, the forest plot was very favorable for TDXd. But just to dig down a little bit on this, if you have a patient with high volume disease, I'm assuming you want an active agent like TDXd as opposed to CAPE. So that patient, you might have a different discussion than somebody who has maybe middling ER positive disease in the bones and is slowly, kind of progressing in those types of sites.
Yeah, exactly, especially for the patient with visceral disease. And when I worry about liver, when I worry about pulmonary functions, I sincerely tell them that we need an effective agent and I need the treatment to work efficiently and absolutely, and I would absolutely favor TDXd, and by looking at all the data. I would be okay with the oral agent more for those patients, thank you for pointing it out, more indolent, bone only, and they already had a long PFS from prior oral agent. Those are the patients I'm a little bit more comfortable.
Got it. And then, touching on that a little bit, one of the nice things about a drug like TDXd is just the response rates, right? Like, it's been reported to be as high as 60% for all responders, and including some CRs and even some of these ER positive studies. Has that been your experience in general as you've used the agent in your practice? My
clinical experience is actually more than that. I just felt very rarely I have patients not responding to it. It's a matter of the PFS. Is it going to be a little bit shorter than the study or way longer than that? I actually have patients in the ER positive HER2 negative setting has been on TDXd for over 2 years now. Oh, wow. I did not start it. It was actually started at the time when we were still running the DB06. And my experience has been positive, and this is how exactly when the patient has a high volume of disease, and I would prefer to use it in the way my confidence that the treatment is working is higher.
Yeah, and and you touched on this also a little bit, your experience in terms of tolerability for your patients, have you had basically the same distribution of challenges in terms of safety signals, but also just tolerability, or has it been different in your hands?
I would say ILD is actually less than 10% in my hands. Okay. Perhaps it is more in the clinical trial setting, and quite some patients received other chemotherapy. In my hands, I did have ILD, but it's definitely less than 10%. I sincerely share with my patients that, per the report, it's 10%, but in my hands, my experience has been actually lower than that. Okay. Alopecia does happen, especially grade 2, but I only have 1 or 2 patients so far, so it was less than 10% in my hands. So nausea and fatigue are the most common one that I deal with, and for me, it's not just a nausea, because associated with nausea, I schedule dexamethasone, I schedule olanzapine, and they gain weight. And those often the time are the younger patients I'm dealing with, and cancer is controlled great, but I'm dealing with weight gain, and that's actually often the time what I struggled, and I had to figure out a way to manage the side effects and without compromising the quality of life, because it's no longer just the PFS and OS, and we are getting greedy, and we want great quality of care for our patients too. So nausea and fatigue actually are the ones I deal with the most. ILD, and we are getting more comfortable, and it does happen, but we have a very good strategy to manage that, and I'm comfortable to manage those side effects.
Yeah, we won't talk about it yet unless it comes up in the questions, but this idea of holding the drug for toxicities like ILD and then restarting it seems safe and feasible, and people can get quite a bit of durability after restarting it. But do you favor dose reductions, or do you give, for patients who are really having fatigue, do you just give a break in the therapy and then restart it later? Walk me through that a little bit. I'm curious how you tackle that problem.
It depends on the side effects. I'm a very stubborn oncologist.
I remember that.
It's an effective agent in the way there is data that you look at the relative dose intensity, and especially if it's ER negative, and my patients do agree with me that let's figure out if there is any other reason for the symptoms you are experiencing. And often the time when the patient has fatigue and we automatically felt, well, has to be from TDXd, I diagnose vitamin B12 deficiency quite a bit. And it could be, and also exercise was reported at ASCO, and it can improve quality of life too. And I'm a strong advocate of exercise, and also make sure we are not missing any other etiologies of the fatigue. And I do my best to refer them to rehab and to make sure I'm not missing any other interventions. and I only reduce the dose when I exhaust all the possibilities and the patient is miserable. I do reduce the dose, but I have to make sure I look into all the other etiologists. I'm very stubborn that way.
I think that's appropriate. You know, this is a dangerous disease, so you want to give the patient every chance. And I have a similar practice, quite frankly. I try to optimize on everything else. But every now and then I do have to give a patient a break, and then when it's time to restart, I restart. And I'm actually emboldened by the data, even though it was for a different reason, it was for ILD reasons.
Yeah.
Patients who hold the drug for some reason, if you restart it, it seems to have a lot of value still. So that's really, I think, important.
Yeah, I did do that in the past too, and it could be sometimes actually the patient need to take a vacation, need to be out of country for a month or two. They ask me the question, is it safe to hold the medication, and tells them, yeah, you have been having great disease control, and I'm totally cool about that, and I agree. Give them a break in the very careful situation, and often the time they still benefit.
So and before we leave this portion and start talking about subsets and everything, for patients who are on TDXd, and unfortunately they start to progress, is it hard for you to reach for another drug? Are the patients still in, quote, good shape, or are they beat up by fatigue? Like how hard has it been for you to reach for a different agent if they've had clinical progression on TDXd?
I have not had too much issues with that. And you know, in general, I do not feel they are beaten up. The longest patient on TDXd in my hands are over 3 years now.
Okay.
She actually has been with ECOG of 0, and she has been working full time. And even for some patients with a lot of volume of the disease, and I have not experienced the patient was so beaten up by the treatment to the point they cannot receive the next line treatment. It has not happened to me at all, you know, just by thinking about it.
I actually have a similar story. I have a ER positive patient that ultimately she progressed but was fatigued from the therapy, and I was a little worried, but I was able to get her screened and put on her phase 1 trial. So, you know, she was able to go on a research study even afterwards. So I agree. I don't want to undersell this. This is an important thing, the quality of life for our patients and their fitness to do something else. But it seems like for our well-managed patients, there are still options available for them, and we can reach for almost anything at that point.
Yeah, I think probably I had 1 or 2 patients that they decompensated. It was because of disease progression. I truly did not think it was from the medication.
Correct. Yeah, and that's hard to control.
Yeah, it's hard to see it.
All right. Well, now I think it'll be fun to talk about this a little bit. There's been some updates at San Antonio, and again, just past week at ASCO on subsets, you know, patients.
We love subgroup analysis,
all
right?
the subgroup analysis. Well, you can torture the data only after the trial is positive. So the trial is positive, so we can torture the data and find populations. But high-level impressions, where are you seeing patients that, we talked about disease burden and things like that a little bit, but you know, there's some worrisome subgroups. People who have certain mutations in their cancers, et cetera. So what's your impression? First of all, tell me about that, and what's your impressions of the data?
Yeah, there are some patients, you know, I tend to worry about, you know, the patient with PIK3CA mutation and TP53. I think everyone probably were burned. I had a few patients in the past with PIK3CA mutation. I did not even have any chance to give them more than 1 line of therapy. When the cancer progressed and they have liver failure and pulmonary failure, and they die really quickly. And those are
this is even with HER2 positive patients.
And with HER2 and, you know, with PIK3CA, when I see it, I tend to be more aggressive and make sure I'm not missing any effective treatment. And the TP53 is another interesting subpopulation, and they tend to be more aggressive, and I don't have very effective targets for that, and I tend to worry about them.
And what about ESR1? You know, this is an ER positive cohort. Tell me about, first of all, have you noticed any associations with progression in ESR1 and lack of response or good response with TDXd, that kind of thing?
No, I actually have not.
Okay.
And you know, for the ES1 mutation, of course, you know, it's booming with all the SERD. I feel grateful for that. You know, in the past, fulvestrant would be the only option, but now we have multiple clinical trials on the SERD in single agent in combination with different treatment. I'm very grateful for that. But you know, when it comes to TDXd, I have not observed difference in response, and I think that goes along very well with the reported data too.
Got it. And I know right before we got on camera, we were talking a little bit about this. Erica Hamilton presented on the podium in the metastatic session at ASCO just a few days ago, and she went through these biomarker subsets. Obviously, when the trial was designed, there was this biomarker secondary analysis.
Yeah.
They had ESR1, which we talked about a little bit. They had PIK3CA. They also had BRCA1 and 2, which I thought was
quite
really
interesting.
Yeah, so
I know.
Tell me about that.
I of course, the patient with BRCA mutation, and I was burned, and I think I probably asked you back in 2018 that she had BRCA mutation, the cancer just did not respond to any treatment, and she had a lot of pain, and she died miserably. So I'm very careful with the BRCA mutation. Of course, we would anticipate PARP inhibitor is very effective. And I was very, very happy to see the data that that population actually responded very well. I was very happy to see
even
it.
Better.
Even better.
Right,
I know.
Right.
Yeah.
I think just so everybody knows, when they looked at all these subsets, the hazard ratios, I think is the most appropriate measure for these. If you look at the numeric difference in PFS, they were really preserved. It didn't matter if you had a mutation or not. PIK3CA positive versus PIK3CA negative, same responses, same difference, same delta. Same with ESR1, hazard ratio, again, 0.4, 0.4, everything very consistent. But the one that was most striking was the BRCA, which is almost suggested an 80% benefit.
Yep.
Small cohort, small group of patients, it's hard to, but the magnitude of it was so big that it becomes believable. And even though it's a little bit off topic, we saw this also a little bit with the other ADC that we sometimes use, trastuzumab govitecan. So I started thinking, is it topo-1 inhibitors? Is that the magic? And we were talking about that. So what's your thoughts on mechanism for that benefit in that subgroup?
Yeah, I was actually thinking about that, and it was more the DNA damage and the mutational burden, and I have not come up with any other hypothesis. Do you have any other hypothesis?
No, I think it's the same. We see benefit from platinum agents. We see benefits from anthracyclines even in this group. And is it a big stretch to say a topo-1 inhibitor could offer the same benefit when that's a chemotherapy payload? So it'll be, we'll all think about it. I got academic friends, right? They're going to probably come up with some prospective studies to flesh that out a little bit. But it's an interesting finding.
Yeah, it's interesting in a way that HER2 and BRCA are almost exclusive in the way that it's very rare for us to see HER2 positive in the patient with BRCA mutation. And that's kind of interesting, and I was just trying to come up with the possible explanation for that, and perhaps with the different DNA damage pathway, and it's not the HER2, it's more the payload.
Yeah. All right, pivoting again, moving us along. So we talked about patients exhausting endocrine therapy, and then you reach for this agent. Some patients you might reach for something like capecitabine. For the most part, you're reaching for this agent. Let's go back a step. So you have a patient who's been on endocrine therapy, and in theory has another line of endocrine therapy. Are there triggers for you to leapfrog against another endocrine therapy line? For example, if somebody has an ESR1 mutation, you obviously have a drug like elacestrant versus this drug. Are there characteristics of patients that concern you where you skip a line of endocrine therapy and reach for something like an ADC like TDXd?
Of course, I'm not perfect, and I hope there is perfect markers and clinical factors for me to consider. But looking at the patient population, if they had a shorter PFS from the prior line, and let's say it doesn't matter if it's PARP inhibitor or CDK4/6 inhibitor, if it's shorter than 12 months, especially shorter than 6 months, I don't feel good to continue endocrine therapy. Or they had a lot of disease burden, visceral disease. I'm very particular about liver mets, and I had multiple patients when the bilirubin start to rise and they can have liver failure pretty quickly. I do not have the time to wait for 2 months to sit on the cancer. And also when the patient start to lose the ER, and it can start with 100%, but with more treatment pressure, they can be only 20, 30%. That's the population I don't feel good to stay on the endocrine therapy. And it's almost in the same scenario we start to call those patients endocrine refractory, and without TDXd, we would have offered them chemotherapy anyway.
Yeah. So you're slotting, your behavior and your approach to those patients hasn't changed. It's just you have a different agent.
Exactly.
I got
yeah.
it. I totally agree with you. You know, patients who don't have essentially a zilch response to endocrine therapy, even with the new agents that we have available, it's highly concerning that there's some other driver we're not appreciating. Hypothetically, let's say you have that patient with large volume disease burden, you feel uncomfortable, you give her T-DXd, she gets whatever response she gets out of it, how many ever months or years. Do you ever backtrack and go back and grab an endocrine agent?
Oh, I did.
Yeah,
I did.
Okay.
I actually, I have been running quite a few phase 1 clinical trial, KAT6 inhibitor, CDK2 inhibitor, and we had no limitation to the prior lines of therapy. And after they progress on TDXd or chemotherapy, I put them back on the endocrine therapy. They actually can have good response to the treatment.
Okay. So anecdotally, at least, you know, your experience, if this doesn't burn a line in theory, it just repositions lines if you have to use it earlier than you thought.
No, if anything, you know, I'm looking at that. Perhaps after we give the treatment, the cancer cell a little bit endocrine break, and perhaps they may even respond better. It's just my hypothesis, and I have no scientific evidence yet regarding that. But I did have patients actually respond to endocrine therapy after they progressed on TDXd.
Wonderful. So I think last portion I want to talk to you about, we talked about a lot of stuff, how you find these patients, your decision making, the features of patients, the subgroups, where the evidence is. But the last, I think, important piece is, and you touched on a little bit, is the patient communication piece. First of all, how do you describe this drug to your patients? Like, how do you convince them that it's different? And I'm just curious on your narrative.
Yeah, so first of all, I live in Seattle and I practice in downtown Seattle. A lot of the patients are so well educated, and even before I recommend any therapies to them, they already read about it. They actually ask me, a lot of patients ask me about it. And you know, when I try to explain to the patients, and I try to explain to them, this is not conventional chemotherapy. This is a very targeted therapy, smarter, more effective, and safer. And I explain to them, you know, we are targeting the HER2, and even it's chemo, but it's engineered onto the antibody. So it is only when the antibody anchor on the cancer cell, that's when the chemo molecule is released surrounding the tumor's environment. So most of my patients will be like, oh yeah, that's a very smart design. And I like to use that word. It's a smart targeted bomb to the cancer cell. They like that description.
Got it. So, you know, I've got the numbers here because I couldn't possibly memorize this. Say you have a disease, a patient with lower volume disease burden, fewer than 3 METs. Their PFS is 15.3 with TDXd versus 8.4 months with standard of care. Hazard ratio very good there, of course. And then even in those with more than 3 METs, 11.4 versus 7.2, hazard ratio 0.71. So we're seeing really good activity across the spectrum.
Yep.
And is that ever, like, do you ever say, hey, look at this data, you know, this is kind of what we see, or is it just by feel you try to explain it to them?
Oh yeah, absolutely. So typically, you know, of course, I will not remember all the data. But you know, what I remember off the top of my head is that, you know, when I even have fewer disease and the duration you stay on this treatment doubled. And when I use the word doubled, it's impressive.
Yeah.
And a lot of patients was like, wow, that's impressive. And my confidence that it's working is higher, and most of them are impressed by the data. Of course, you know, everyone would want to own an effective option, and that data is quite striking.
So obviously we've got the top line data, and the top line data, main criticism is it's always an idealized patient population. Additional criticism, it's done in Asia, it's done over here, it's done over there. How does this, you know, reflect on my patient population here? So we're trying to find that data, right? So just give me a sense of how important to you is the data that we see from things like real world evidence, and do you follow or track real world evidence, and what does that teach you, or how does that help your practice?
Oh yeah, absolutely. I think, you know, nowadays with AI, with technology, the real world data is way better compared to the real world data we had 10 years ago. So, you know, there are a lot of data from the real world experience. It's quite important for me to look at. So I do look at the real world data, and I carefully by looking at the data, and I think it's actually great data for me to look into. And recently, actually, I'm participating quite a few studies and using the real world experience and to explore the data. I totally agree that we do cherry pick a little bit, especially for the phase 1, phase 2 clinical trial. They have to be a good clinical trial candidate because we do not want a lot of dropout rate. And when it comes to real world, and this is what I do every day, and the patient can be more fragile and it can be different. So for that, I truly appreciate the real world experience and the data, and I do look at them.
And the real world evidence so far, at least with this agent, in your view, is it tracking differently than the top line data from the big trials, or does it look the same? Is it?
It looked very similar to
agree.
me.
I thought it looked the same.
It looked very similar,
Yeah.
and that's how I felt reassured.
Yeah, and what about the toxicities? So your real world, in terms of, it seems a little bit better, but when you look at the toxicity data from the real world evidence, are you seeing anything?
No, it
different
looked
there?
very similar, and I have not noted any alarming discrepancy and make me worried. I have not noted any. Have you noted any?
I haven't. It's
Yeah.
and I knock on wood, I'm having a very similar experience to you. We are coming on late and have a lot of experience, and also can lean on our colleagues to say, hey, how did you do this and that, and getting through. I did want to touch on this a little bit. We talked about nausea a little bit. Obviously, this drug, it has a higher level of antiemetic coverage. Have you incorporated the new NCCN guidelines into your framework of how you practice?
Oh yeah, absolutely. I do give triplet IV pre-medications prior to each infusion, and after the infusion, I routinely schedule steroid and olanzapine. I've been quite successful. The only thing I'm dealing with is often the time it can cause weight gain, and yeah, it's great. Your cancer is controlled, but that has been mitigated by tapering the steroid. But for some patients, if I have not done so, the nausea rate upfront get-go can be high.
Got it. Yeah, I think olanzapine is a gift.
I know.
It makes a huge difference,
Yep.
and I still hear of patients in the community who are not getting it, so I think it's important for us to talk about it and get the word out on that.
Yeah,
All right.
it was. Yeah, the data on olanzapine was published almost 10 years ago, and I cannot believe that. But
Yeah.
it has been a blessing, and it has been very helpful.
Yeah. So, last question, open-ended. What are you excited about? In the near future on what either with TDXd or kind of other things, just have at it, whatever you want to talk about. What's exciting?
Yeah, so the data in the patient with brain mets were surprising to me. Again, I'm stubborn. Initially, I was like, oh, I don't believe those data. It's such a large molecule. But the more data I'm looking at, I'm actually quite impressed. So, and yet I don't understand the mechanisms yet. Yeah. So
well, let me ask you. Let's
Yeah.
talk about this a little bit, because we've been mostly talking about HER2 low,
Yep.
other than when we were talking about DB09 briefly. But that data that you're referencing is from a trial focused on HER2 positive.
Correct.
So maybe you can walk us through the two sets of data there and what we saw in those.
Yeah, of course, when it comes to the HER2 positive setting, we know the chance of brain mets is high. And I think it was reported in ASCO, look at the intracranial response, and the data looked good, and
good,
it
yeah.
looked even better than the TKI.
Yeah.
And in the past, I was stubborn in the way that it's brain barrier, and I would prefer TKI, and the data was interesting and surprising.
So let me ask you the unfair question. So that was all HER2 positive
Yeah.
driven cancers. Between us, have
Yeah.
you used it in HER2 low patients?
Yeah.
Okay. And what's been your experience in that setting?
I actually have a young woman. She has been having brain mets from 2019, leptomeningeal disease from 2021, and she's stable on TDXd.
Wow. Okay. And that's
She's
in
ER positive.
That's in a
HER2
HER2 low setting. ER positive,
Yeah.
HER2 low. Wow. Okay.
Yeah, I'm really, really proud of that, and that's one that I have no problem to adopt the data, especially for the patients with brain mets, and the data looked really amazing, and I did not believe it initially,
Yeah.
to be frank, but the data looked really great. And get back to your question, what I'm more excited about, it's working great in the metastatic setting. I would be looking forward, how can we move it up to frontline, that's a DB09, and also early stage, and especially for those patients, high-risk brain mets and a large volume of residual disease, and I'm looking forward to the data.
And again, to back up a little bit, that's specifically focused on patients with HER2 positive disease. In the HER2 low disease, is there a future for a drug like T-DXd in early stage disease?
That's a unfair question.
Yeah.
I don't know,
Yeah.
and I don't think we have any clinical trial in the space in the way we are talking about PARP inhibitor and CDK4 inhibitor in the setting.
Well, even DXd.
Yeah,
right?
even DXd.
Yeah.
I don't know. I don't know the answer to that.
I don't either. I thought I'd ask the question because we're talking about, essentially we're talking about two diseases, right? HER2 low and HER2 positive, of course. So any final thoughts on, before we invite our guests to kind of ask questions from us?
So how do you feel about all the newer data? What do you look forward to for the use of TDXd in future?
In the future, I think in the same thing. It's been important to march it up. What I want to know is, in the DB09 setting, I'm very curious about how do we do an induction version of that, because we do have other options for especially the ER positive patients right now. And I just want to understand the treatment sequencing, so it'll be interesting for me to see if there's an off-ramp for some patients, because I know I can go back to it based on some of the re-challenge data that we have. And then in the adjuvant setting, I'm with you there, how do we squeeze this drug here? The ideal situation is to not deliver people into the metastatic setting by letting them recur, right? And so, I say this to you all the time when we're together, but our job is to put ourselves out of business, and this drug is helping us.
I will be very happy if I have no patients to see. I will be very happy.
Yeah, absolutely. We can do different things then.
Yep.
All right, so I think at this point we can invite folks to kind of come along and ask questions. Okay, Dr. Erdick.
Hi, thank you for a great talk. So I was just wondering, going forward, I guess, there were a lot of patients that may have been HER2 0, may have been ineligible for T-DXd. So is it, I guess, reasonable that repeat biopsies could detect these?
So Fengting, why don't you tackle that one? We didn't really touch on this, but this idea of enriching for HER2 signal over time, and I think that's related to this question about what we do with the HER2 zeros historically. How do we go find them now? What's your strategy on that? That's a great question, by the way.
It's an excellent question, and I call my pathologist first, who is absolutely wonderful and awesome. And I truly, especially when it's difficult to biopsy, if it can just go back to the archive tissue, and if I can diagnose an ultralow, I don't know why I want to repeat a rebiopsy. And I have been successful with that. So I actually had a patient, I had to go back to the tissue. She had a biopsy at UW, and 10 years ago, we were able to locate that and get it done. It is when there is a challenging issue, when I absolutely cannot repeat it, I cannot get that information, that's when I repeat. And also we know that the HER2 IHC, and we need to fix the tissue in a certain time frame, and the HER2 expression can be fragile. So if I truly need a good option, but traditionally it was a 0 and I cannot get good information or data, that's when I try a rebiopsy.
Yeah, and just to go back a little bit, in the Dana-Farber experience, they published this and presented this on the podium at an ASCO not too long ago. And they basically showed that with each successive biopsy, the probability of you gaining some level of HER2 staining continued to increase. And that was in an ER negative subset, but I think all of us suspect the same is happening in an ER positive subset of patients as well. So I agree, finding patients who are eligible for this therapy is super important, even if it involves reassessing the tissue. That was a great question. Next question, I guess. Oh, Dr. Lambley, how are you doing? It's good to see you. Maybe you can tell us what's on your minds.
Hi, good to see you too. I guess just to build off of that same question, there's a lot of discussion in the pathology world that HER2 0 isn't an actual category. And so is there a future investigation looking at TDXDs irrespective of HER2 IHC?
So the question then, just to reframe it, is HER2 0 a real thing? And then do we reframe this? So walk us through kind of your thoughts on that.
Yeah, absolutely. I do wonder that, and I totally agree. And is HER2 going to matter? And we keep pushing that, it's initially HER2 positive and HER2 low and HER2 ultra low. And I did lab research in the past. If you look hard enough, you will see some signal, very weak signal. We don't know the answer yet as of today, but end of the day, I don't know the answer to that. And with AI, I'm just wondering if we can incorporate AI into the HC evaluation, or maybe we should quantify the number of the HER2 receptor. I think that will become possible pretty soon. I'm wondering, could that be a direction that we can head into? I don't know. I don't know the answer to that.
Yeah, I've been thinking about this as well. So just when one develops an ADC and then they have a target that they can identify, we have this thing called an H-score. I'm not going to share the formula with you, but across a spectrum of up to some quantitative number, you have very high levels of expression and you can get down to very low. There are patients that truly have no expression, and with many of these ADCs you really don't see any activity on that end of the spectrum. So there probably is a legitimately HER2 zero cancer cell, but the tissue itself, you may have groups of cells that are slightly positive and others that are not. So there's this level of heterogeneity, and that might be positive. I guess there's a chance that every cell is zero, in which case these drugs probably don't work well. But if you see any, the estimate is that when you lump in HER2 zero ultra lows along with the HER2 lows, it's 85% of the cancer. It's probably more than that if you really look hard enough. But yeah, I think it's still an open question.
Yeah, it's still a question, but as of today, we still need to prove there is some HER2 signal, and it needs to be ultra low for me to offer the medication to my patients. But my experience has been the same, that it could be zero by HC and negative in the past, but along the way, and it can become ultra low or even low. I truly agree to that. I probably only have very few, maybe one patient or two, that I absolutely cannot find any HER2 signal throughout the cancer history. Almost, my experience has been more than 85%.
Yeah.
If you look hard enough, and we will find some HER2 signal.
Yeah, I have a
somewhere.
handful of patients where I just keep testing their pleural effusions over and over and over, and it's still not possible.
Okay, so you have more than I do.
I do have those patients.
Yeah, it's I'm not sure if for you it's about 15%. I just felt it's lower than that.
Yeah. All right. Yeah, that was a great question. Who else has got something for us? Hey, Dr. Kinsey.
Hey, Kinsey.
Hey, how's it going?
I just had a couple of very practical questions. One is for when you do have a patient with pretty severe nausea or fatigue, which I agree with Fengting are a couple of things that can come up. Have you guys found that dose reductions actually make a big difference? Because I don't know that I have necessarily found that. And then my other question is, I have some patients who have now been on TDXd for a long time, and I'm just wondering how long you continue to image them more frequently than you otherwise would. And I just don't recall off the top of my head, like, what is the range for seeing ILD develop? How far out can you see that still arise?
So first question, I maybe tackle that one, which is dose reductions, and do you find that to be helpful? And again, you're the mean oncologist. You already said that.
I'm the stubborn one. And
oh, stubborn. Sorry.
No, sometimes my patient was, oh my God, I'm scared to report side effects to her. I'm nice. Truly, I do have a few that, regardless of what I do, the nausea continue to be there, and it's frustrating. And that's when I start to reach out to gastroenterology, and I'm not very shy to request an EGD. And it turned out that they actually had ulcer, and two patients of mine, they actually had a metastatic cancer in the stomach, and that's how they had those GI symptoms. It just did not resolve. Again, I'm stubborn in the way I'm trying my best to look for other etiologists, but most of the time, especially nausea and fatigue, most of the time, I do not want to say 100%, they got better with dose reduction. Of course, with the second dose reduction, I start to get anxious. Is it still effective? Most of the time, I'm successful to mitigate by lower the dose most of the time.
Okay.
Come back to the second question. I got more laid back after they are stable on TDXd for 2 years. If you look at the ILD, it's accumulative, but it plateaued after 2 years. Of course, for the first 2 years, and I teach everybody, I'm doing the CT around the clock, not just to look for disease, I'm looking for ILD. If we catch grade 1, I can still resume it, but if it's grade 2, I will have to discontinue. It's important for me to look for the ILD.
And just to back up, what's
Yeah.
the frequency that you're looking for ILD in your practice?
Oh, I have been doing it every 3 months or 12 weeks.
Okay,
and
12 weeks.
I have not felt I missed much. In a
Okay.
way, the median time is about 5.5, and I felt I have been able to catch the ILD I needed to catch. But after 2 years, I totally understand everyone is concerned about contrast, radiation exposure, and a lot of patients had imaging anxiety and the anxious prior to imaging. So I start to space out the staging scan after 2 years.
Okay. And Kinsey, you're a pretty busy practice. You see a lot of breast patients. Is that what you're doing as well?
I initially screen every 9 weeks, but I have to say when patients have been on it for a couple years, it's hard to maintain that, and maybe even before a couple years, it can be hard to maintain that. And so then, it would be nice to space it out.
All right, that was a lovely question and an important one, I think, because ILD is something you definitely want to keep your eye on, but at some point it would be nice to give
space
patients some
out.
quality of life and
Yeah.
some time from scans, et cetera. Yeah. We have another question.
Yeah, do you think I answered this before, but just a very personal, specific question for a patient is that patient was 43 years old, previously HER2 low 10 years ago, and now has recurrent pleural effusions that we've tapped 10 times, HER2 zero every time. And I want to find any excuse possible to give her an HER2, so I'm going to try 11th time, but I think this is kind of to the question earlier of these patients. Do you treat based upon a HER2 low from 10 years ago, or do you treat with an alternative regimen not involving an HER2?
I have an answer, but I'll let you go first.
Yeah, so my question would be, was it ultra-low?
Yeah.
Yeah, so my question would be, I would call the pathology up and I would ask, is there any signal, is it ultra-low? That would be my
In the pleural
question.
effusion.
In the pleural effusion.
But now let's say that's still ultra low. I mean, zero.
Zero,
Pleural
zero.
effusion, 0, 0, 0, 0, 10 times, 0, 0.
I would be hesitant to offer TDXd in the way that this is a bigger beast that we are handling, and we need to control the pleural effusion. If it's truly legit negative, and I most likely we can get TDXd approved. But my question would be, is the patient going to benefit from that? So I probably will reach out something else.
So I have I'm going to disagree with you for the first time tonight. I think if you have a prior specimen where you have HER2 low expression, you could go for it. Part of the issue with HER2 immunohistochemistry testing is this absence of comparator tissue in a metastatic site. At least with a metastatic site, you have tissue, but with a pleural effusion, there's no control tissue at all.
That's
so you can't
true.
benchmark HER2 really at all. And so you would miss an ultra-low potentially. The patient I referenced earlier actually was a TNBC patient who actually, even in the primary site and even in the metastatic sites in her skin, et cetera, always zero. That patient I genuinely believe to be HER2 zero. But this, I think, got a positive biopsy from before. I actually, personally, I would give it a shot in this patient.
Oh, that's a great point.
Yeah.
Thank you for asking the question, because I would, that's a great point. It is, that's a great point.
Yeah, I think we don't have a lot of corpus of data around things like pleural effusions and staining them. I would give this lady the benefit of the doubt, frankly, and say, okay, you had a positive specimen at some point for low expression, maybe go for it.
So I'm going to ask a follow-up question.
Okay, go for it. I love how you interview me too.
So let's see, the primary tissue was HER2 low, and now you have a liver biopsy and it's zero, and you don't believe it, a repeated liver biopsy is still zero, negative. Would you consider offering TDXd?
It depends on the site of progression. If the liver is the sole site, then I would be a little worried about that. But if there's multiple sites and you just happen to hit the one that didn't have it, I kind of would give the patient the benefit of the doubt of the most active agent you have. Unfortunately, tissues have heterogeneity, and it could just be a liver sampling issue as well, even in that scenario. I literally saw a case today in our tumor board where there's HER2 2+ staining on just a small population of cells, but the rest of the tissue is kind of zero, and so this happens. You just don't know where the needle is on that day, and so that's the downside of tissue-based biopsying, of course.
Yeah, that's an excellent question. I was just impressed by the 11 times, and I start to doubt myself.
All right, lovely question. Anything else? Oh, Kalyan Banda, Dr. Banda, welcome.
Hey, Dr. Banda.
Another favorite was in the lab with you and at the same time.
Yeah.
Kalyan, what's going on?
Well, yeah, I have a sort of a tangential question, and that's in the setting of ERBB2 activating mutations, let's say exon 14, exon 20, maybe
Got it.
exon 21.
Got it.
Then a TKI makes total sense. But what is a Herceptin doing there? I'm always puzzled by, why you would need, or why, like tucatinib plus Herceptin was the combination, not just tucatinib.
Yeah.
And related to that,
Yeah.
in lung, there's an approval for TDXd with activating mutations. And in that case, is it because you think the activating mutation makes it more sensitive to a topo-1 inhibitor, or is it that you speculate that in those activating mutations, they just had 1+ HER2 expression, and that's where they were actually responding?
All right, so questions are both tangential and speculative. Go.
Yeah, and actually, I was discussing a similar case with one of my coworkers not a long time ago. I published a case report on a patient with leptomeningeal disease and ERBB2 mutation a couple of years ago. And I agree that for those patients, they are not HER2 overexpression, but ERBB2 mutation. In my mind, TKI makes a lot of sense. There was a publication in Nature a couple of years ago, beautifully laid out, depending on different ERBB2 mutation, which TKI potentially work better because they can be targeting different domain of the kinase. So I totally agree, for the patient I had, because she had ERBB2 mutation, I did not even think about what do I want to give her IV trastuzumab. So I gave her capecitabine and tucatinib. She actually had a complete response initially, PFS over a year with leptomeningeal disease. And that's why I reported, but when the manuscript was in revision, every single reviewer was asking me the question, why you didn't give this patient trastuzumab? And my answer was well, I would not think that would have helped. But that raised the question, how much trastuzumab is doing in that setting. I doubt it's going to be helpful in the way this is the mutation, this is not the overexpression. But I'm open to your idea.
Yeah, so
about
there's
that.
some preclinical data and clinical data as well that downregulation of HER2 at the cell surface can facilitate the functioning of the TKI molecule. So that would be the explanation for some of the rationale for combining, and that's why the data, it's not been published in typical clinical journals, it's been in Nature Medicine and places like that, but that's kind of the observations. And then the lung data, again, I'm speculating. I think we know some lung cancers have HER2 expression, and a lot of them have activating mutations.
Yep.
If the protein is on the surface and you can tag it, TDXd might work, and I think that's really the theme there with lung cancer and why that approval makes sense.
Yeah, but truly, I do think come back to the breast. If there is ERBB2, and I don't recall off the top of my head. There is some preclinical data that TDM1 potentially may be effective. So in my brain, I think TDXd should work too, but I don't recall any data off the top of my head.
Yeah.
Yeah.
That's a great question, Colleen. All right, Ali.
So actually that answered one of my questions because, sometimes we're not able to get a biopsy, we're not able to get the last pathology, and we're just able to get liquid biopsy, and on the NGS you see the ERBB2, but there's no way for the liquid biopsy, for the IHC, so that's one of the obstacles. But anyways, I had two questions. The first question is, do you see, or do you, in your head, do you think the objective response is going to be different for HER2 IHC 0, HER2 IHC, Ultralow 1+ and 2+? That's the first question. And the second question is, how do you think about the efficacy of Datroway or daratumumab, deruxtecan, completely different mechanism of action as the next line of therapy after HER2?
Oh, got it. All right. It was
Excellent
only a matter of
questions.
time. Let's mark the time. The ADC after ADC question was posed. But before we tackle that one, maybe you can talk a little bit about the amount of quantitative and then what type of responses you expect.
I'll be quick. Before the data was published, I was those HER2 2+ patients should benefit better than the 1+. the data look exactly the same. It doesn't matter, and as long as there is some HER2 receptor on the surface, it works. So that's a quick answer. And ADC after ADC, and I'm actually gradually switching myself. In the past, I like the sandwich. I truly believe that if the payload is similar, that we got to give something between. And I'm actually slowly, gradually switching that. I don't want to give ADC after ADC in the way. Again, I think it's important to move up and make sure we prioritize the more effective treatment, give them those effective treatment first, and I do not want them to lose the opportunity to get an effective treatment.
Yeah, so it's interesting, going back to this H score, it's funny because a HER2 2+ in theory responds better than a HER2 ultra low.
Yep.
But compared to the comparator arm, both outperform the comparator arm. So the hazard ratios are the same when you do like comparisons, but when you look at a patient with high level expression and slightly lower expression, there's a difference. They're still better than chemo for both scenarios, but there's a difference. So I think that's the way to explain that. And then, I agree with you on the other
ADC after ADC.
Yeah,
I know I was very stubborn for a while.
I'm still stubborn, but I think there are lots of good agents, so I'm going to reach for them. We'll see. I think the payload is more of the issue than the targeting part of the ADC TROP2 versus HER2 in the case of Datra versus trastuzumab deruxtecan, obviously.
Yeah, I agree. But at the end of the day, we don't have perfect data, and it would be ideal if we understand why that patient is progressing. Is that because of the payload?
Mechanism of resistance is key.
Yeah, that's important. We just don't know.
Yeah. All right, great questions. All right, Dr. Lee.
Hi, I just had questions about HER2 DX score, prognostic score. I would like to know how you feel we will start using it in the neoadjuvant, chemotherapy decision and adjuvant and then metastatic.
So the question is this ASCO presentation that was just made, I think it was Nadine Tung, the HER2 DX score looking at the COMPASS study. Basically, it's a clinical pathologic scoring system that's available where if you're high on this scoring system, you seem to have a better response, a more likelihood of pathologic complete response. Are you using anything like that in your practice?
I have not adopted yet in the way we are going to give those treatment anyway, but it is interesting to see that actually there is really good chance of PCR even with THP. So I truly think we should actually adopt those clinical factors and scores and to tailor the neoadjuvant treatment, because quite some patients might just get PCR from the THP to why do we want to give them doublet chemotherapy, and I think this is the way to go. I'm just not ready to adopt it fully yet.
Well, and you highlighted this in just your comments, but at ASCO there was a study called, I think, NeoCarp or NeoHARP, this Chinese study where they essentially dropped the carbo and didn't see any loss of PCR rate. In our practice, we actually have a clinical trial as well where if we order the MammaPrint biomarker and the blueprint assay, and if we get a HER2 enriched subtype, we're feeling it's okay to de-escalate from carbo in those patients. And so far, anecdotally, we're seeing good responses. So to answer your question, there's lots of biomarkers, clinical and otherwise, that I think are being developed. Personally, I don't think any of them are just ready for prime time to say we're going to change our practice. But I think we're getting really close, and it'll be interesting to see if it's just a clinical versus a more biomarker like a gene expression test or something like that.
I still believe it's a combination of both.
Probably both. All right.
Great question.
And I think one more. Hi, Nancy.
Hey, Nancy.
I'm asking the kind of a little bit opposite question. When to stop TDXd? So for HER2 low disease, so after treatment achieved basically no active disease. So that's one. Another one is for HER2 positive. Similar situation after TDXd, such a good response. No active disease. How long to keep that? Like for the first patient, had a dose reduction, just about the fatigue, very profound. After dose reduction up to 50%, I don't want to. I think further reduction will be meaningless. So when to stop?
All right, so the question is when to stop in both types of patients, the HER2 lows and also the HER2 positive. Your thoughts?
We don't have data to make me comfortable. Again, I'm stubborn. We don't have good data for us to stop at any point. And the concern has been if I stop the treatment too prematurely and if the cousin come back too quickly, how much response we're going to get. I feel comfortable to give them a break, but I'm not comfortable to just start to discontinue for all the patients. I'm just wondering, perhaps, that if we have good biomarkers and MRD, can we use MRD to guide those treatments? I totally heard everyone that nausea, fatigue can limit the quality of life, but as of today, I do my best to keep it going, knowing that we don't have good data how long the treatment will be. Think about Herceptin. We have stage 4 patient on Herceptin for 10 years, and we have to do a clinical trial to see what is the time to discontinue. Yeah. I don't have a good answer for that, and I do my best to continue, and I'm hoping that we will have more clinical trial to answer that question.
Yeah, I totally agree. We need more clinical trial data. I do, I have thoughts. So one thing I will do, at least in the HER2 positive patients, is in those patients where there's no detectable disease, they have a complete clinical response. I have cheated a little bit and used whatever biomarkers I can get. If it's protein-based, fine. Some patients, if it's ctDNA, even though it's not very sensitive, I will use that, and then we can have a discussion with a patient to say, okay, it might be okay to back down from this. For the HER2 positive, it's a little bit different. You can't, when patients have indolent bone disease, you can't really tell sometimes. Yep. So I'll try to use whatever markers I have, and I'll treat the best clinical response, and then it's a negotiation with the patient. In some ways, one of the most important studies out of ASCO, just practically speaking this year, was the one I referenced earlier with Hope Rugo, where they looked at re-challenging patients across 5 academic institutions, for patients who had grade 1 and in some cases grade 2 ILD. They looked at across any disease. It didn't matter if it was breast or lung or whatever. And basically, they were able to re-challenge patients, for the most part, safely. And those patients got durable responses even after that, right? So this idea that if you're stopping it for anything other than progression, you might be able to revisit that. That's not a new concept. We've done that with the taxanes. We've done that with the platinums and ovarian cancer. So maybe it's something we can do here. But again, data-free zone, but that's just clinically, how we're practicing.
Yeah, but getting back to the ovarian cancer, 5% of my patients are ovarian cancer, right? We do that. When they are platinum sensitive, we give them a chemo break and wait for the next progression. And I think we can consider that. We just don't have a guideline, and we just don't have a good marker. So I would be very excited to wait for those results, and hopefully we have more results. Right. Yeah.
Well, Fengting, first of all, it warms my heart to be here with you and to have you be a peer on something like this. So just thank you again for being here. And to the folks in the audience, I know so many of you, many friends here, really appreciate your attention, your great questions, some that challenged us even, and hope to run into you at the next major meeting. And you please tap us on the shoulder and say hello.
Yeah, thank you, V.K.
All right.
I learn something every day from you.
Thanks. Bye.